Welcome everyone on MRCOG Part 2 Essential Guide, the free webinar. I am Dr. Rubab Khalid, and I am a full-time qualified medical educationist. You all know me. I'm a blogger and I'm a mentor at RK4 courses. And here is all the information through which you can contact me and get guidance about MRCOG Part 2 or Part 3 at any time. So the agenda for today's webinar is that I keep getting a lot of queries related to the exam format, how to prepare in the right direction. There are so many queries, and I hope this webinar will clarify those queries. So what we are going to do is first we'll look into the MRCG Part 2 exam format. I know some of you have taken the exam previously and you are aware of it, but it's always a good idea to review and revise what is the exam format, because until and unless you understand the exam format, you will not be able to crack it. And then we'll see how you can start your preparation and how we can help you in your preparation. And then we are going to discuss very briefly GTG 51 monochorionic twin pregnancy, which was recently updated, and it's a minor update. So I'll be focusing on the updates in the guideline and a few points which are important. We'll not go into so much detail because I want to keep this webinar as short as possible. And at the end, we'll have a short quiz which is going to be helpful to you, and you can test your knowledge about the GTG 51, whatever you have gained. So let's begin with the exam format. So this is MRCOG Part 2. All of you have taken the Part 1, and so you are aware that this is a computer-based written exam which is conducted with the help of a third party Pearson view, and all the information for booking the exam, it's given on the website, and I'm sure that you are aware of that. And please, it's my advice, whenever you want to get the updated information, the best place to get it is the RCOG website. Okay, so just keep visiting the RCOG website for the updated information from there. So MRCOG Part 2 has 2 papers, and both the papers have 50 SPAs and 50 EMQs, and the distribution of marks is like 50. The SBAs, they carry higher, they carry 40% of the weightage for the marks, and EMQ carry 60% of the weightage. So that means EMQs, they have, like, they are more higher scoring than the SBAs. So regarding the exam, it's a 3 hours paper, 3 hours each, paper 1 and paper 2, and you have around about 60 minutes lunch break. It's generally recommended by RCOG that you should be giving 70 minutes to single best answers and 110 minutes for EMQs, because even though they are 50 EMQs, but still EMQs take more time. And the information which is tested in single best answers, it's mostly factual information, which you can find mostly in the beginning parts of the talk articles or the guidelines, which is about the percentages, the numbers, the incidences, the prevalences, the facts. And EMQ tests your in-depth knowledge, and the clinical questions, clinical based scenarios are there, and clinical application of your knowledge is tested in extended matching question. But remember, the whole of the paper, MRCG Part 2, both the papers, they are actually, you have to choose the single best answer. In single best answers, you have 5 options. In extended matching questions, you may have probably 15 or 20 options. So you have to choose more options, choose from more options, and that's why EMQ becomes a little bit challenging. Regarding the syllabus, because before you start preparing, you must know what is required from you. Then I would say that it's all provided on the RCOG website. You may have noticed that they have changed the curriculum on the website. Previously, it was updated in 2019. Now in August 2024 also, they have updated the curriculum. So if you have noted down, now what they call is, like previously, we used to call the, the topics which are covered in the obstetrics and gynecology. Previously, they were called modules, but now RCOG calls it as knowledge areas. But remember, the basic information or basic knowledge, whatever is required, has not changed. So that means the basic content of the syllabus is not altered, just that they have given it another name, and they check your capabilities in practice, and all this information is provided on the college website. Please visit the college website for the most updated information from there. So these are the knowledge area. Previously, there were 18 modules which were tested in MRCOG Part 2, but now they have divided it into 15 knowledge areas, as you can see. And if you see, these are the same things, almost the same modules: core surgical skills, post-op care, antenatal care, maternal medicine, labor and delivery management, postpartum problems. Then comes the gynae problems, subfertility, sexual and reproductive health, early pregnancy care, gynae oncology, urogynecology. So knowledge areas are the same. So you have to prepare according to the knowledge areas, according to the modules. And you know that I have provided a lot of information on my blog with each modules, the compilation of the modules, what is expected to study in each module, and what is the reading resources, how to get about those reading resources. So that could be an excellent resource for you to start your preparation and to start collecting the important exam resources. Continuing with the exam resources, so what is basically, like, where does the question come from? And this is a very important slide. We'll spend a few minutes on this. The first thing is that whenever you know that, okay, you have chosen a module and you have chosen a topic, and you know that you have to read that topic. So RCOG produces green top guidelines, and there are around 75 green top guidelines, and you need to learn each guideline by heart. No one can pass the exam without reading green top guidelines by herself or himself. So green top guidelines are regarded as Bible for MRCOG exams, okay? So you need to be really well versed. So that's why as soon as a new guideline or a minor update even comes in the green top guideline, that becomes your hot topic for the exam, like, upcoming July exam. So this GTG 51 is going to be a hot topic for you. Then comes, if a topic is not covering green top guideline, then the next resource is NICE guidelines. So there are a few topics, around 15 to 20 NICE guidelines, which cover the obstetrics and gynecology topics. And then regarding the contraception, FSRH guidelines are there, and this is a subsidiary of RCOG. So whatever the information is given in those guidelines, you have to follow and learn that by heart, because contraception is a very important module, and it is tested in a lot of complex scenarios as part of EMQs. Okay, and then for the sexual health, we have the BASH guidelines. This is the most important one, the TOG articles. A very common question is about the TOG articles. How many years TOG articles you must read? So I give a very interesting answer for that. I'm like, if you join me, I will tell you, last 3-year TOG articles you have to read by yourself. But previous ones, probably you can rely on the summaries. Okay, so at least the last 3-year TOG articles, you must know what is happening. And I'll give you a tip. If you find there is a TOG article which is about a guideline, and it has come after the guideline, and you see that they are talking about something, anticipate that the new guideline will be out very soon, because first they discuss it in the articles, in the TOG articles, and the important topics, they include the important topics only, and you need to know how is the what are the articles published in the TOG. And you have 4 issues of TOG each year: January, April, July, and October. So if you're going for the July exam, you need to be prepared till the January 2025 TOG articles. Okay, so you need to prepare that, so that if there is a question, you are able to answer it according to the updated information. Then college also produces scientific impact papers, and that is also around 70 plus scientific impact papers. And that is the second most reliable resource after Green Top guideline, because this paper, these information is from the RCOG, and you have to follow that. And if there is, I'll give you a tip here, if there is a conflict between some figure or something, scientific impact paper says something else, the TOG article says something else, I would go with scientific impact paper because that's from RCOG. And then for consent for different procedures, there are consent advice papers, and I have compiled the consent advice papers also, and you can just get it from my blog also. There are 12 papers, 14 consent advice papers about different procedures. You need to know these very well because you are tested in the exam related to the advantages, the complications, the frequent complications, the serious complications. And these questions are usually tested as part of single best answers, and they are straightforward scoring questions. So there is no chance that you should be making mistakes in these questions. And there are around 6 clinical governance advice papers are also there. And then few good practice and best practice papers that also you need to cover for a few topics to understand how the systems work in UK. So if you read these papers, especially these 3 ones, these papers give you an insight how they work, how things work in UK. Okay, because most of you are taking the exam and not working in UK, and it's difficult to know, to get an insight into a system. But if you read these papers with that intent, you will be very clear and you will not be making any mistakes in the exam. And then maternal mortality is very important, and Embrace UK. So every year in December, these reports are produced. So before you take the exam, at least read the previous 2 years reports, and you must know what is the current maternal mortality rate, what are the causes of direct maternal mortality, what are the causes of indirect maternal mortality. And actually, this is an excellent example of an audit. So if you read one Embrace UK report properly, you will have a very good idea how an audit is done, and what's the importance of specific topic, why some topics are more frequently tested in RCOG exams. Then in UK, there is a very well-organized colposcopy screening program, and for that we have a separate guideline, and that you need to learn by heart. That was updated in February 2020. Okay, and all these exam resources, as I told you, I have provided this on the, not only on the blog, but also we do provide all these resources on our RK4 courses learning management system as well. Now, coming to the books part, right? So for the books, I have just put here a few standard books. I have 3 points to talk about the books. First of all, follow and practice as many books as you can, and whatever the books are displayed here, please do practice these books. But look at the books publication date. Some of the books are kind of outdated now, because there are so many new information, so many new guidelines are out. So this information is kind of outdated. So please look at the publication date. And if you are solving a question, you have read a latest guideline, but the answer in the book is different, just leave that question, just skip that question, because what you have learned is more correct than what is given in the book. So that's one reason why we cannot really rely on the books, because books take a long time to be updated. But if you have the access to online courses or access to material in the soft form, that's more easy to update, and you get the most updated material related to the books. And then whenever you have any doubt about the answer, please cross check it by yourself. Now we have a lot of tools. The Google is there, ChatGPT is there for you to help use artificial intelligence to crack this exam. And the exam preparation becomes very easy if you prepare your exam smartly, right? Now, the question is, now you must be thinking, right, I have taken the exam previously, or I know all these things, whatever you are being told over here. But how do I prepare? How do I prepare the exam in a way that I'm going to pass? So that's the question every student has. The first thing is that you have to understand the exam. You might be working in your place as a very senior person, probably as a specialist or as a consultant. But for this exam, you are an ST5. You are in a middle level of training. So you need to think like an ST5. Understand what this exam wants from you. Go to the RCOG website, download their syllabus, look into the depth of the curriculum, what is expected out of you in a particular topic, and then you will be doing it. And then plan the exam and plan it very well. If you have passed recently part 1 and you are moving to take part 2, until and unless you have been preparing it for a longer time, I would suggest that at least give 6 months of good preparation, because this exam needs a lot of time. This exam requires, it has a financial strain also, and it will drain you emotionally if you cannot make it. So whenever you are planning to take it, take the exam full-heartedly. Don't do half-hearted preparation. Don't take half-hearted attempts, because in the long term, that's going to be really bad for your mental health. And once you fail, you get into that trap that I cannot do it, and you want to do it also. And like, just mark my words, don't go and take the exam without at least 3 revisions of the syllabus. First reading would take 3 to 6 months. Proper study of the part 2 syllabus. It will take 3 to 6 months. Okay. So this is what educate time you need to give. And your approach should be very positive approach. And you need to organize yourself, gather the reading material, and put them into a format where it's accessible to you. Make a study schedule. It's very important. A doable, a realistic study schedule, and give appropriate time to the modules they need. Short modules such as early pregnancy care, maybe you can do it in 10 days, but maternal medicine is a huge module, so it will take at least 20 days for you to prepare and cover all the topics and guidelines and the TOG articles. So what I suggest is, first of all, note down the modules, the sequence of the modules you are going to do. Allocate, okay, I'm going to give these days, these many days to this module, and then afterwards break down each day also. So what are you going to do in that day 1, day 2, day 3, day 4, and keep some time for unforeseen circumstances, keep some time for breaks, and make a schedule by keeping in view, okay, you may have more work, you may be on vacation, your child may have exams, maybe you have to travel. So keep all those things in mind, and then make a doable study schedule. Okay. And never ever forget to make your notes. No matter how many good resources you have, how many courses you join, until you make your notes by yourself, you have your own idea, you will not be able to revise it. So make notes with keeping in view how you are going to come to that topic again before your exam. Okay. And in the notes, make notes smartly. Don't write everything which you already know. I mean, you read a guideline, 10 times you read a guideline, and you have learned the guideline, and you will be looking at the same information which you have learned. There is no use writing though that information which you always remember from your undergrad or from your some local country exams. Write only those things which you think can be tested in exam as single best answer or extended matching questions, or you have come across that point somewhere in the book, somewhere in the previous exam questions. Write it down and write those things which you tend to forget. And you will see an immense change that, okay, you have learned many things, and focus on the areas which were deficient in your preparation or deficient in your reviewing of a guideline. I mean, you read a guideline, today, if you read a guideline, let's say, after 2 days, just take a paper and pen and just try to jot down what all you remember from that guidance, which is exam related. And you'll be surprised that how much you remember, okay? And practice the questions, single best answers and EMQs, and about the recall questions, okay? So previous exam questions, they are important, but it's humanly impossible for anyone to come out of the examination hall and revise and remember all the 200 questions, full stop. So whatever the thing you get from the previous exam questions is just, just a glimpse that how the exam is like, nothing else. You are getting a view from the candidate who had taken the exam, not your personal insight. And I have been, into MRCOG exams for the last 7 to 8 years. And trust me, I have seen every time the candidates, when they share, they tell, I ask them, how's the question, how the paper was, paper 1 was difficult, paper 2 was difficult, so and so. And when they say this question came, that question came, more or less the questions are same. Only 10% of the questions would be from the latest Green Top guidelines or from the TOG articles. So the theme, remember, RCOG is a very traditional college. They have a question bank, they have a question pool, and if they change one single word in a question, the whole answer changes. So please use your own brain, because when you are taking the exam, you are sitting inside the cubicle, in front of the computer by yourself. You are all alone. No one is there to help you. So make these reflexes right from the beginning. There are so many times you ask someone, one mentor, a question, the other one, they will give you variable answers. Don't trust anyone. Trust your instincts. Trust yourself, whatever you have read and whatever you have understood, because you are taking MRCOG Part 2 exam because you are super intelligent. You are above 70% of the people, of the population. You are really brainy. You don't need to rely on anyone. Trust yourself and be confident when you are taking and when you are preparing the exam. So MRCOG Part 2 July exam is around the corner. You need to keep an eye. By 25th of March, you have to send expression of interest. And it's open. If you are planning it, please do send it, because if it closes, RCOG will not acknowledge and you will have to wait till January 2026. Booking will open on 22nd April. That's very, very important date. You need to be ready as soon as the booking opens. Book your exam because the seats get filled in very fast. I have a tip here for the booking. If you're taking an exam from a country and your city is not mentioned, just choose any city which is nearby in your country, because you can always change it. It can always be changed, and you can manage to travel within the country and take the exam, and it's worth it. If you are prepared, and if you are preparing for the last 6 months or a year, if you are prepared, I think it would be really not nice not to take the chance and book your exam now. And the exam will be on 2nd of July, right? And results will be out on 30th of July. So they have the whole exam calendar. They have mentioned till 2025 calendar only. January 2026 calendar is not updated yet on the RCOG website. So now, before I start GTG 51, I'll just quickly, briefly give you just 5 minutes I'll take of you to give you an idea how we can help you. We have variety of courses available on RK4 platform where you can choose a course of your choice, your requirements, and your needs. Okay. So we are going to start MRCOG Part 2 live revision course from 11th of March, and this is the anticipated schedule. So we'll have twice weekly sessions, and we'll have around 12 to 15 sessions, and all the important green top guidelines, important org articles, they will be covered in there. And we do have a modular mock, and I'll have a practice with you also in the today also. I have a short small 10 questions which we'll solve afterwards. So we, after every session, whatever we study, we have, those question practice is from the previous exam questions, which are famously called recall. So we practice those questions, and everyone gets to participate. Everyone participates, and you can see how much you have scored and what's the correct answer. We have an open discussion over there. And of course, those stems and those scenarios are from previous students, and they are sometimes not complete, but I just discussed these so that you to give an idea to those, especially to those who are taking the exam for the very first time. And then we have a special session on clinical governance and teaching also. And teaching is my field. I'm a qualified medical educationist, so teaching module is not a difficult one. So we discuss different methods and the questions which are asked. And statistics is also provided on the website. Statistic module is information is also provided. You will have the session recordings until the exam date, and there will be a WhatsApp study group which you can utilize. And if you wish, you can join us, because we are, the early bird discount is about to close soon. And then we have this one of the most comprehensive course, the e-course. All the reading material is provided in the format of written e-course, and this is accessible for 6 months. So you can join this at any time, and it's all instantly available. And then we have the essential videos course also, all the green top guidelines, the nice guidelines. There is about 150 plus recording are there, and you can just listen to those recordings, and you do get free access to the question bank also, where we have 1300 plus SBS and EMQs, and that also you can solve. And this is also a very highly rated course for us. And then if you can subscribe to all these courses individually, and if you want to save money and you want to have a comprehensive preparation, we provide it as an option in the bundle also, and it saves a lot. Everything is given on the website. Then we have these talk written summaries. It's a short course available for 3 months, and it's updated till January 2025. Round of, I think 115 plus talk articles are available. The written summaries are there, and you can download the original talk articles as well. And then if you want to just subscribe to the question bank, so you do have this also, and it's also keeps updated along with the latest talk articles, single best answers also. If you just want to have the GTG written summaries, that's also available, and that's also updated till January 2025. The latest one is yet to be updated, and it will be updated within a week. So these are the options you have. If you choose, if you want, if you are on your own, that's good. But if you need, we are here to help you. So before we move on to the GTG 51, do you have any question? I'm here to answer anything which is not clear. Yes, any question? Any session of governance? Yeah, okay. Dr. Faiza, thanks for your question. Clinical governance, we conduct it as a part of, the revision sessions. And in the essential videos, the clinical governance recordings are available. In the written e-course, the clinical governance notes are also available. And I'll tell you something. The clinical governance is a topic which you need to understand. You need to apply clinical governance principles on all the 200 questions of the exam. And when we are revising in the live sessions, I emphasize on that you need to think from the perspective of clinical governance. Clinical governance is not a separate thing. It's like it's an umbrella which is like, responsible for all the patient safety and all the positive outcomes for the patient and for you, for the doctors and for the paramedics. So clinical governance sessions separate is not available. I do conduct it as part of the revision sessions. Okay. Any other question? I guess we can move on. All right. So now let's discuss the green top. All right, Dr. Faiza, I've noted down your query. Just contact me on the WhatsApp, so we'll see how we can go about it. It's not available as a separate module, okay? But we will see. You just contact me, right? So now, why I choose this topic to discuss, because GTG 51, it was published in 2016. And after that, in 2019, NICE guideline was published, which is about the twin pregnancies and triplet pregnancies. So they have updated this guideline. It's a very important guideline. And it's a minor update. RCOG says it's a minor update, but we will see what that minor update is, because you really need to look deeper. What are the different things? If you're reading it for the very first time, no problem, because you have not learned it and you are learning new. But if you have learned the previous one, you will need to see what are the changes. So I'll be talking about those changes, and we'll see what they have given. And this is the first slide. And in my sessions, in my notes, in my given material, my first slides are always the most important ones, because that contains the crucial information which is tested in single best answers. Epidemiological things, the percentages, the prevalences, the incidences. And why it is important is that they give you this information so you will understand what is the importance of a specific topic. That gives you an insight why there is a green top guideline, why there is a TOG article. So the introduction and epidemiology part is very important as far as the MRCOG exam is concerned. So in UK, 20% of monochorionic twin pregnancies are there out of the whole twin pregnancies. And now this is a different figure. Previously, the figure was 15%. Now they have changed it. In the guideline, the figure is 20%. So now they said that rate of twinning in higher order pregnancies is more in the Nigerian ethnicity, but there is no increase in monochorionicity. So Nigerian ethnicity, so this is important. That's why I put it in bullet in the bold format, because you may have a question in the exam where the woman is Nigerian, and that's what they want to test. Okay, so Nigerian ethnicity, they'll have more chances of twinning. Then artificial reproductive techniques are becoming very common, and this increases the risk of both monochorionic and dichorionic pregnancies. There is no difference, right? Day 5 blastocyst transfer, it significantly increases the rate of monochorionic pregnancies as compared to the day 3 transfer. So that's important information. You may be tested on that. Then monochorionic pregnancy, why there is a green top guideline? Monochorionic pregnancy is associated with increased risk of preterm labor, growth restriction, preeclampsia, postpartum hemorrhage, postnatal feeding problems, and mood changes. And overall, if you compare monochorionic pregnancy with dichorionic pregnancy, it has increased risks of fetal and perinatal loss. Monochorionic pregnancies have single placenta, and almost all the placentas, they have vascular anastomosis. So that means their fetal circulations of the monochorionic pregnancy are interconnected. So monochorionic pregnancy comes with special challenges. There are special complications which are present in monochorionic twin. Twin transfusion syndrome. This is about 15 to 20%. Now, once again, this figure is changed. Now, the chances of TTS are increased. Previously, it was 15%. Now, it's 15 to 20%. So, there is a change. In about 60% of TTS, you find velamentous cord insertion. Previously, it was 50%. So, you see there is a change. And then TAPS. TAPS is twin anemia polycythemia sequence. This is a complication. And in monochorionic twin pregnancy, it occurs in about 20% of the patients spontaneously. And this complication is a special complication which occurs after the treatment of TTS. Okay. And this may occur in about 13% of the cases after the treatment of twin transfusion syndrome. Okay, so we will be talking about it in a short while. Another complication related to monochorionic twin is growth restriction, selective growth restriction. So without twin transfusion, selective growth restriction is in about 20% of the cases. Whereas if the patient has developed twin transfusion syndrome, then growth restriction is about 60%. And in this guideline, they have emphasized more on how to deal with the selective growth restrictions, and they have incorporated the points from the GTG 31 small for gestational age guideline on also. Okay, so they have changed the recommendation for monitoring, and they have added the middle cerebral artery pulsatility in velocity to look for fetal anemia. So if you look into this slide, it's a very important slide, and I can easily make 6-7 single best answers from this one very first slide. Okay. Now, what are the key changes in this guideline, right? So the key changes in this guideline, number one, in the previous guideline, they talked about non-invasive prenatal testing, and they say that you need to be cautious. But since 2016, over the period of 8 to 9 years, they have found the evidence that cell-free fetal DNA for trisomies 21, 18, and 13, they can be used as a contingent test screening pathway in monochorionic twins. So they can be used. Previously, they were giving you a caution, but now they say now you can use it. And diagnostic classification of selective growth restriction is to be used. We'll be coming into it. And this is what all uncomplicated monochorionic twins should have an ultrasound at 2 weeks interval, which will start from 16 plus 0 weeks until delivery. And by the way, this is a recall question, a very, very important recall question. And umbilical artery Doppler will start from 16 plus 0 weeks until delivery. And umbilical artery Doppler, actually, we are doing it to see the risk of twin transfusion syndrome. And this is a new addition. To assess for TAPS, to screen for TAPS, middle cerebral artery pulsatility velocity is added, and that is also to be done from 20 weeks onwards at each scan. So this is the new addition. And when they have given the frequency of monitoring also, in that chart also is changed. I will show you over there. At the end of the guideline, they have given the appendix regarding the glossary of terms. I noted down there is no change. It's the same thing, and these glossary of terms You need to understand, to know the short forms, what are the standard short forms which are used all throughout the guideline. Now, this is the most important change. TTS Quintero staging. Okay, there is a bit of change here, so we'll spend a little bit time here. So there's a table given, complications which is associated with intertwin vascular anastomosis. So we know that TTS is the main complication, and that is graded with the help of Quintero staging. And this is present in about 15% of monochorionic twins. Now, these are the staging. So here is a difference, that there is a significant discordance. Stage 1 is when there is a significant discordance in amniotic fluid volume. How do we define it? Oligohydramnios with the help of deep vertical pocket. Deepest vertical pocket is less than 2 centimeters, or polyhydramnios in the other sac more than 8 centimeters DVP before 20 weeks, or more than 10 centimeters DVP after 20 weeks. And whenever you are scanning, you need to look at the fetal bladder also. And stage 1, donor bladder is visible, and the Doppler, umbilical artery Doppler, they are normal. So that is, TTS is developing, but this is stage 1. Then it progresses. Stage 2, what happens in stage 2? The bladder of donor twin is not visible, and there is severe oligohydramnios in the donor twin. And Doppler studies have started to become abnormal, but they are not critically abnormal. Right? So this is stage 2 TTS Quintero. What happens in the stage 3? Now the disease is progressing further. There is a problem with the blood circulation. So Doppler studies are now critically abnormal in either the donor or the recipients, and abnormal umbilical artery Doppler velocities are there, and in the donor, or abnormal venous Doppler velocities in the recipient. So these velocities, Doppler becomes abnormal. So in short, you can say in stage 3, the Doppler studies are critically abnormal, full stop. Now, what is stage 4? Now the disease is progressing. Stage 4, there is ascites, pericardial or pleural effusion, scalp edema or overt hydropsis present, and it's present usually in the recipient. You need to focus here. Here it may present in stage 3, it may present in the recipient or in the donor. But in the stage 4, the recipient will have hydropic changes. Okay. The donor will be small, and recipient will be hydropic. And the stage 4 is the most serious condition, where one or both babies have died and it's not amenable to therapy. So you have a window of treatment in stage 1, 2, 3, 4, but if stage 5 has happened, it cannot be reversed. So this is how this Quintero staging is done. A very, very important staging, favorite RCOG question. And if you look at the guideline, the table is really small. It's written in very small letters, difficult to see, small size of font. So that's why I have just taken one portion and put it here. So you need to make these things clear and memorize and remember what it is. And by the way, the information what they have given here, they have incorporated this information from the NICE guideline. If you have read 2019 the NICE guideline, you may have noted the same information is given over there. Not that the GTG is also recommending it. Now, this table continues, and it has this complications related to TAPS, selective growth restrictions. So you can just go through it, because for this session, I will be focusing more on twin-twin transmission syndrome, okay, TTTS, because TAPS and SGR, it will take another 1 hour to discuss in detail, but we will discuss only TTS, how to diagnose and how to manage, okay? Let's keep it short. So the guideline begins with the diagnosis. So how do we diagnose monochorionic twin? That's a very important question. And now they say that you need to do a booking ultrasound from 11 plus 0 to 14 plus 1 weeks to assess the fetal viability, and you look for number of placental masses and membrane attachment to placenta and its thickness. The membrane thickness is so important because now they have given this picture. This picture I have taken from the green top guideline itself. So they say that if there is, the membrane is thin and it's like a T sign, that means it's a monochorionic twin, because it's so important to establish the chorionicity. Because if you establish the chorionicity, if it's a dichorionic, you can be relieved. But if it is monochorionic, all these special complications are related to it, and we need to be extra vigilant for it. Okay. Now, for dichorionic pregnancy, there is a lambda sign. So lambda sign means the intraplacental membrane is thick, so it gives a lambda sign. So that means it's a dichorionic pregnancy. So that's a major difference. You may be given these pictures in the exam and maybe asked a question related to it. So ideally, chorionicity and gestational age should be estimated before 14 weeks, because afterward it becomes difficult. Just in case a patient comes late, then you can do fetal sex determination, and if there is discordant fetal sex, then you can be confident that this is a dichorionic twin pregnancy, and that is incorporated in as a new point in GTG 51. And they are really emphasizing on keeping the electronic image and documenting the appearance of membrane attachment to the placenta. That's very important. You need to put it in patient's notes. Now, there may be certain situations that even though you have done a scan and the sonographer is not sure what kind of chorionicity it is, seek second opinion. And still in doubt, refer the patient to fetal medicine specialist and they will see. So you may have this information tested as part of a complex extended matching questions. A patient comes to you, you have sent the patient for scan, and the sonographer is not sure whether it is monochorionic or dichorionic. What should be the next step? Next step is to seek second opinion. Or the scenario says that you have referred to a second sonologist also, but still you are doubtful. What should be the next option? Then the next option would be fetal medicine specialist. So that takes me to a very important advice related to EMQs, is that please read the question very carefully. Focus on each and every word given in the exam. Okay. And now they say that it is so important at the time of first ultrasound that you assign nomenclature to the fetuses. Fetus A should be with amniotic sac closest to the maternal cervix. And you need to keep this nomenclature consistent all throughout the pregnancy monitoring so that you are not confused. And in case a fetal medicine specialist has to do some procedures, he or she should be the one performing the scan so that he or she should know what they are going to do. And in the guideline, they have said that it is required from the people working and being trained in fetal medicine specialist unit that they should be performing at least 15 cases in a year. That's the minimum requirement from them to maintain their capabilities up to the mark, up to the standards. Now, manage the pregnancy as monochorionic until proven otherwise. That's the take-home message for it. Now, in the guideline, they have mentioned, I will not go into the reading into this slide, but just know that they have talked about the outcome of monochorionic twins. There are chances of fetal loss, chances of perinatal death, preterm birth before 37, extreme preterm birth before 32 weeks, or small for gestational age. And they have given the comparison. They have quoted different studies. They have given the comparison that what happens in dichorionic, what happens in monochorionic, diamniotic, what happens in monochorionic, monoamniotic twins. So you can just go through this because this is going to give you an idea that I'll just tell you how to read this information. Monochorionic twin pregnancy is associated with higher fetal loss and higher risk of neurodevelopmental morbidity. So you see, dichorionic twins have fetal loss around 2%. Monochorionic diamniotic has around 7%. And if it's monoamniotic, then the chances are 3 times higher. That means it becomes 21% or around to 22%. So I deliberately kept these percentages as points. No, I'll give you a tip here to read the percentages in every guideline in any talk article. Now, you can round off these numbers. If it is 7.7, you can just mark in your mind, okay, it's around 8%. And if it is 21%, that means it's around 22%, 21.8. So this 9.3 would be round off to 9%. So like this, you have to understand this and try to memorize it, so that if you are asked, not specifically particularly to this information, I'm just telling you any other information you come across when you are preparing for the exam, just learn to compare and just learn to round off the number, so that in the exam you are not confused and you are good to go. Right. Now, regarding the optimal screening, in this guideline, they are talking about the different screenings which we offer during pregnancy. So first, they are talking about the chromosomal anomalies. So for that, for the twins, we offer combined test in line with the national screening program. And in that case, we check for knuckle translucency and serum markers, and that is done between 11 plus 2 to 14 plus 1 weeks, especially when the CRL is 45 to 84 millimeters. And we record it at the time of this combined test, at the time of booking scan. We record the CRL, we take the CRL from the larger fetus. Okay, that's important point to note. Now, combined test has a sensitivity of 90% for twins, and it has false positive rate up to 10%. I have highlighted this because this is important and vital information. Combined test is effective, and if you see, for singleton pregnancies, the false positive rate of combined test is round of 3%, 2.5%. For dichorionic twins, it's 5%. But for monochorionic twin pregnancies, its false positive is 10%. So you need to be vigilant. You need to be looking into the other signs which may be helpful for you to diagnose what is happening. Okay, so be vigilant, interpret these results very carefully. And in this combined test, we calculate pregnancy specific risk. If it is a dichorionic twin pregnancy, we calculate fetus specific, but here we will be calculating pregnancy specific risk. Now, another information, a previous recall question, what percentage of women miss their first antenatal booking in first trimester? Previously, they had quoted the number was, it's a famous number, 5%, but now this number is also 10%. So that means 1 out of 10 or 10 out of 100 women, they are missing their first booking scans. Okay. Now, if they miss, then you have to offer them second trimester quadruplet scan, and once again interpret the results with caution. Now, this is another new information, non-invasive prenatal testing, routine contingent screening test. They have found out that for trisomies, it has detection rate of 99%, trisomy 21, detection rate of 99%, and false positive rate of 0.002%. And for trisomy 18, detection rate is 92.8% with false positive 0.01%. So that means now the evidence is available. That means it's an effective method, and you can reliably find out whether the baby is suffering from trisomy 21 or 18. Okay, so that's going to be helpful. Now, continuing with the optimal screening, we have to talk about the structural anomalies. And for that, we offer monochorionic twin pregnancies, routine anomaly scan, which is done between 18 to 20 plus 6 weeks. And that must include the extended views of fetal heart anatomy. And when you compare, when we are looking into the structural anomalies, some comparison, some interesting comparison actually is given in the guideline. They have compared the monochorionic with the dichorionic, and they said that overall there is higher chance of fetal anomalies in monochorionics, 2.8% versus 1.3%. So it's almost double chance of fetal anomalies. And more anomalies are diagnosed in first trimester in monochorionic twins. Around 50% they are diagnosed in the first trimester, the major anomalies. Now they have talked about a pattern of detecting the anomalies. We all know that ultrasound can sometimes pick the anomaly and can sometimes miss the anomalies. So the pattern is the same. It doesn't matter whether it's a single pregnancy or twin pregnancy. The picking up from the detection from the scan would be the same. So what the guideline says is the anomalies which are always detectable, and I found it information relevant, and I anticipate there could be a single best answer from here. Always detectable anomalies which are easily detectable are acrania, A-lobar holoprosencephaly, encephalocele, pentalogy of Cantrell, axonpholos, body stalk anomalies, twin reversed arterial perfusion sequence, and congenite twins. So these are the anomalies which are always detectable. So you can be asked as a single best. Now, talking about the optimal ultrasound regime, and this is the table which is new. So what have they added in here? If you have previous guideline, you can compare it from here. What they have added here is from 16 week, you will check for the fetal growth, estimated fetal weight, DVP, and middle cerebral artery peristaltic velocity. This is the new addition here, because this is what we are looking for, and we are, why these recommendations? So I have added it as a separate box for you to clarify. Between 16 plus 0 to 20 plus 0 weeks, we do 2 weekly scan to detect twin transfusions, okay, TTS. TTS is rare after 26 weeks. So the golden opportunity, the window of opportunity is before 26 weeks. That is why we start fortnightly scans from 16 weeks. And we are doing this MCA PSV from 20 weeks onwards because we want to screen for TAPS. And this is the new addition. Twin anemia polycythemia sequence is checked. Okay. And after 26 weeks, why are we doing the scan after 26 weeks? That we are doing it to detect the selective growth restriction or concordant growth restriction. So this is a very important one. You see 16 weeks, 18 weeks, 20 weeks, 22 weeks. Twin pregnancy is not an easy thing for the mother, for the obstetrician. It has a economic burden, it has the financial burden, and it has the a burden on the hospital resources also. You see the woman is coming to the hospital multiple times and having these growth scans as well as the Doppler velocities. So you need to be really understand the follow-up, and you must understand, not only understand, but you must know why these are the recommendation and this is the change in the guideline, right? So Dr. Faiza is asking, will we do fetal echo routinely? We will not do fetal echo routinely, but what they say is that we have to at least look at the fetal heart chambers. And if you find any changes, of course, the patient, this baby, this woman will be referred to the fetal medicine unit, and over there, these further studies will be performed, okay? Not routinely. Now, so this is what I was just discussing. How do we discuss for screen for TTTS? First trimester screening is not recommended because that's not reliable. They have quoted a few studies in the guideline, but none of the studies reached the significance value. So that's why RCOG is not recommending. This is an interesting recommendation which is added. So what they say is that ask the woman to report subjective sudden increase in abdominal size, reduced fetal movements, or maternal breathlessness, because that is going to give you an idea that there is some complication happening. So you can ask the mother to keep this record also, because you were screening for TTS. And the same thing, the ultrasound from 16 weeks at 2 weekly interval with fetal biometry and deepest vertical pool plus fetal bladder, that we said that we have to look into these things. And if you keep this ultrasound regime, why this is recommended by the guideline? Because this detects 90% of TTS. It has a very high detection rate, and 9 out of 10 times you will be able to pick it up. And this could be a potential single best answer. Now, the guideline says that even though we are doing the monitoring twice weekly, but if there is any concerns, you need to increase the frequency of monitoring at least weekly. So what are the concerning features? So this is the concerning one, and that is quoted from the NICE 2019 guideline. Same thing, oligohydramnios in donor and polyhydramnios in the recipient. So if it develops the same criteria, oligo less than 2 centimeters DVP, and polyhydramnios when DVP is more than 8 centimeter before 20 weeks or more than 10 centimeters after 20 weeks, then we say this is something significant. Amniotic fluid discordance is there, something is happening, so you need to monitor weekly, right? And please pay attention to these small little information, because you see more than 8 centimeter before 20 weeks and after 20 weeks, it's 10 centimeter. This little information, because this information is repeated multiple times in the guideline, this small piece of information may make a difference in your exam performance, right? And another concerning feature is that there is no urine in the donor. That means it's becoming stage 2. And if there is hemodynamic and cardiac compromise when it is evident on the abnormal Dopplers. So if any of this thing starts to develop, you find any of this, increase the monitoring to at least weekly. Now coming to the management of twin transfusion syndrome. So once you have diagnosed as TTS, you have to monitor. Same monitoring, ultrasound, Dopplers, umbilical artery Doppler, middle cerebral artery Doppler, ductus venosus at each ultrasound scan. And staging will be applied with the Quintero's system. And there's something very interesting given here, and I will show you some of the fetal and neonatal outcomes related to Quintero staging as well. They said that this system, you can apply this grading or staging system, but you need to be vigilant. That's why they have incorporated that recommendation for the woman to keep a subjective record of her symptoms, because sometimes this progress is so quick that you think it's stage 1, but next time when you check, it becomes stage 3 or 4. So it's the progress of the disease or progress of this complication is unpredictable. So that's why you need to be vigilant about the monitoring. Optimal treatment for this should be a multidisciplinary team approach, and the treatment of TTTS will be done in fetal medicine centers. And if TTTS is developed less than 26 weeks, the treatment is fetoscopic laser ablation, and this is done with the help of Solomon technique. You just need to remember the name of this technique, because if you do not use this technique, then there is a chance that even if you have treated the TTTS, the patient will develop TAPS. Okay, so that's why. And you say that now you see, if Solomon technique is not used, patient may develop this may have recurrence of TTTS, which is usually TAPS. So for that purpose, what do? We use middle cerebral artery, because whenever you want to monitor for fetal anemia, we look for the Dopplers of middle cerebral artery, because that is 100% sensitive to know whether the baby is developing anemia or not. So once you have given the treatment, fetoscopic laser ablation, monitor the patient weekly for 2 weeks and then fortnightly. And you have to document how the baby is growing. So if the TTTS has been treated, fetal heart ultrasound should be done by the fetal medicine specialist, and patient should deliver by 36 completed weeks. That's an interesting thing which I noted in this guideline. They have written, instead of writing +0 +6, but they said that 36 completed weeks. So what would it be in terms of +0 +1 2? How would you quote it? 36 completed weeks. Yes. Anyone in the chat box? How would you write this? 36 completed weeks. Would it be 36 +0, or would it be 36 +6? Or would it be 37 plus? Yeah. Excellent. That would be 36 +6. That's 36 weeks completed, because 37 +0 becomes 37 weeks. 36 completed week is 36 +6. Remember that. Good. So if the TTTS is diagnosed above 26 weeks of gestation, then you will be giving individual care. So now this is what they have said regarding the Quintero staging. They measure the neonatal outcome in terms of at least one neonatal survivor. So with this stage 1, if you detect the problem at stage 1, there is around of 90% survival chance. In stage 2, 88% survival chance. Stage 3, 67, and stage 4, 50%. Stage 5 is not there because stage 5 is like fetal demise, right? Now, what about the uncomplicated monochorionic twin pregnancies? How to deal with them? So you have to have a documented discussion with the parents, and the timing of birth for uncomplicated monochorionic should be, you should plan birth from 36 completed weeks, that is 36 +6 weeks. And this is also another important information. You see, Dr. Faiza, once TTTS is treated, we monitor weekly. I'll show you this slide. We monitor weekly for 2 weeks. If everything is okay, then we monitor it fortnightly till she delivers, till 36 +6 weeks completed. Okay, that's what the monitoring is, and this is an important monitoring. Okay, right. So timing of birth is like 56% of twin pregnancies they deliver before 37 +0 weeks. A very important number in my opinion. That means almost 2/3 of babies they will deliver before 37 +0. So twin pregnancy is usually a preterm birth. So if any patient is delivering preterm, up to 34 +6 weeks, you have to give maternal steroids in line with the GTG. And if she's delivering before 34 weeks +0 weeks, you have to provide magnesium sulfate for neuroprotection. And mode of delivery depends on the presentation of the first fetus. If the first fetus is cephalic, you can go for vaginal delivery. And if you're going for vaginal delivery, continuous electronic fetal monitoring should be done. And if any other complications or any other risks, go for cesarean section. So this is the last slide, which I thought I would add because this is an important exam question and multiple times asked. There isn't any difference in the new guideline, but still it's a very important information. How to manage if there is a single twin demise in monochorionic twin pregnancy. The first step would be refer the patient to fetal medicine unit. Okay. So what is the risk? As there are placental anastomosis, if one baby dies, there is a risk of fetal death of the other baby. So in the monochorionic, the risk of fetal death is 5%. You see, as compared to dichorionic, which is 3%. So that means it's very high in the monochorionic twins. And risk of neurological problems in the monochorionic twins is 26%. I mean, if one baby die, the surviving baby will have 26% chance that they will have neurological problems. And in the dichorionic, it's just 2%. So monochorionic twin pregnancies are 4 times increased risk of neurodevelopmental morbidity. Potential single best answer. And a recall. So if there is a fetal demise, what should you do? When should you monitor for neurodevelopment monitoring? The monitoring would be that you will do a fetal MRI after 4 weeks to detect neurological morbidity. Remember, it's not done immediately. I mean, you detect a baby at one twin has died, the other twin is survived. So at the time of acute insult or acute injury or acute event, the baby, if the baby has to have something, it will be okay. But the symptoms or the neurological morbidity, it will take some time for the surviving twin to develop. So that is why we do MRI after 4 weeks. And meanwhile, you want to be vigilant whether the surviving baby develops anemia. So you will apply middle cerebral artery perceivability index and you will check the Dopplers. And baby should have regular surveillance with the help of ultrasound, and timing and mode of delivery will be individualized according to the patient's condition. All right. So that's all. Thanks a lot for your time. And now we will take a quiz. And after that, we'll wrap it up. It's just 5 to 7 minutes it will take.